Good morning, students. It's Miss Frederick here. It is now 4:45 a.m. in the morning because I like to record at crazy hours. Um, Today we're going to be discussing Chapter 9. This is for my intro psych class. We're going to be talking about treatment of behavioral disorders, Chapter 9. I also have the PowerPoint posted so you can follow along. This chapter covers a lot of information, but overall it's what I'm going to require for you for the test is going to be pretty darn simple. So, treatment of behavioral disorders. This goes through psychotherapy and biomedical therapy. So we will be talking a lot about both of those things. There's a crash course video you guys can watch, but you don't have to if you don't want to. That's in the slides. It'll probably help your understanding. First, let's talk about psychotherapy, which is a non-biological, non-invasive psychological technique or procedure designed to improve a person's adjustment to life. Okay? Could be any sort of talk therapy is psychotherapy. Ah, my sleep schedule has been crazy. Okay. And guys, remember what I said before, 90% of mental health is self-care. So I think a lot of us right now are dealing with stress and pressure and all that mess. So the best thing to do is not overcomplicate situations. Just be calm and just try to get as much sleep as possible. Or at least get more sleep than me. You'll be doing fine. Freud's psychoanalysis was the first developed form of therapy. Okay, so remember how I said before, Freud had a lot of firsts. He did a lot of good things first. Developed developmental theories, theory of personality. He developed the first form of therapy. I was thinking, well, what did people do before therapy? They locked them up, dude. Religion. People handled mental disorders very differently. In fact, people who were mentally ill were considered essentially second-class citizens. Freud didn't put a stop to that, but he greatly influenced it to what we have today. So Freud developed a theory known as psychoanalysis. This is a technique developed by Freud in which an individual's revelations of normally unconscious cognitions are interpreted. So he tries to look for things that the person says and what the person doesn't say to determine what is in that person's unconscious mind. This is based on the assumption that disordered behavior results from unconscious conflicts and repressed urges. Remember I talked about when it comes to unconscious conflicts in Chapter 7. Whatever is the person deals with that they don't want to deal with on the surface, they can't handle, gets shoved into the unconscious mind. Okay? Freud believed that the only way to help people gain relief from severe anxiety was to enter their unconscious, search out anxiety-causing conflicts, and help them gain awareness of the repressed conflict. So, by helping people face up to what they're trying to hide, they will start to feel better. The aim of the therapy was to quite simply make the unconscious conscious. They wanted you to be aware of what was going on. Okay, so Freud's psychoanalysis had 5 techniques to it, most of which we still use today. First concept, free association. Now the people who've been answering and getting ahead in their response questions kind of sort of got this right. Free association is when patients relax and say whatever comes to their minds. So Freud believed that the actual process of venting repressed feelings would result in a temporary reduction of tension, otherwise known as a catharsis. So whenever you do something to feel better, it's a catharsis. You're feeling angry, you want to beat up on a pillow? Catharsis. It's a reduction in tension. The second thing is dream analysis. This is interpretations of dreams to learn about the hidden aspects of personality. Okay, she talked about how dreams are the unconscious mind's way of communicating with us to say what's going on down there. If I'm having second thoughts about a wedding, my mind will try to communicate that with me via a dream. If I'm having a conflict with my mother, but I'm suppressing it, my unconscious mind will tell me that via a dream. Okay? So Freud believed that dreams are a rich source of information about a person's personality and unconscious. Dreams are important, so he looked at different traits a person had via their dreams. So he believed dreams had symbols in it, what snakes represented, what seeing a dead, formerly deceased loved one might represent, or what a train might represent for some people. So dream analysis is not as commonly practiced, but it is practiced with the people who know psychoanalysis and use it today. Thirdly, there is resistance. Now you see this a lot in a therapeutic setting. If you ever choose to work with people, you're going to experience a lot of resistance, and the key is knowing how to deal with it. Resistance is an individual's unwillingness to describe freely some aspects of his or her life. Freud believed what a patient did not talk about was just as important as what they did talk about, not more important. Yeah, like I heard you talk a lot about your dad, but you don't mention your mom very much. And if someone starts pulling away or starts reacting in a defensive manner in session, that kind of is a tip off that they're getting at the real source of the conflict. So kind of be aware of that, because this is something that therapists and clients deal with today. Hope I'm not going too fast for you guys. By the way, for some reason the structure of these slides, I'm not a big fan of it. I'm not fond of it because the structure of the slide has the resistance like right beneath the slide on slide number 5, so you probably won't be able to see it unless you take it out of slideshow view. Just heads up. Okay. The fourth one is transference. This is a process in which a patient begins to relate to the therapist in much the same way as another important person in his or her life. Let me explain how that works. It's very interesting, actually. And I wouldn't recommend trying to harness transference unless you are a skilled therapist. This is something that does happen. This is when your patient or your client will start to treat you like they were like a daughter, a mother, a lover, a sister, a close family relationship that the person might have some conflict with. And I'm not gonna lie to you, I was a therapist about 5 years ago. And one thing I noticed is people would start, I've had clients call me baby because they looked at me like I was a kid. And they looked at me and they kind of related to me as if I was their child. And for some kids, some some clients, they kind of looked at me as if I was a peer or something like that. And that sort of transfers to things you need to be made mindful of. So it's when the client doesn't see you as a client. They might say that they're in love with you or ask you out. Before I started the job, I heard that some other therapists got marriage proposals. And honestly, guys, if you don't watch out for transference, things like that can come up. Countertransference is also a thing that's not mentioned in the book. Countertransference is when the therapist starts looking at the client in a way that isn't a client. For example, the therapist might see the client as a brother or a partner or a son or daughter. And in a way that can destroy the objectivity of the relationship, because half the reason why most therapeutic relationships work is because a therapist can be objective. And you can say things to a therapist that you can't say to a family member, in which there would be a definite conflict of interest there. So hopefully you guys understand what transference is. There will be one test question about it. If someone feels like they love their therapist, chances are they are experiencing transference. They transfer feelings of another relationship onto the therapeutic relationship. Now, I've never harnessed transference, but I know for a fact that most skilled therapists can harness it to try to figure out what's going on under the surface, what that person's trying to hide. It's actually rather fascinating. The last one, the last technique of psychoanalysis is the concept of interpretation. Freud thought it was important for analysts to interpret for patients the underlying meaning of their experiences, resistances, transferences, and dreams. It's not just important that I get to recognize what a symbol is, but I have to interpret what that symbol means. It's not only important that I have to recognize when transference occurs, but I have to talk about what that transference means for that person. For example, if a client sees me as a mom, chances are she had some issues with her maternal figure. So Freud, like we said, developed the first form of psychotherapy, which is psychoanalysis. It remained the dominant force in psychotherapy until the early 1950s. Very few therapists practice psychoanalysis today, and most have changed many techniques, including paying more attention to the patient's current life and relationships. So, you know how Freud often talked about how someone's childhood experiences affects their adult life. Honestly, you guys, modern day psychoanalysis doesn't cover that. Because modern day psychoanalysis understands that someone's current life is more important than their childhood. Because people change so much, don't they? Psychoanalysis does not work with severely disturbed or non-communicative people. Okay? That's a big thing. So psychoanalysis works with people who are mildly intelligent, relatively young, intelligent, successful, and highly verbal. That's why psychoanalysis doesn't take off as a main behavioral force. So psychoanalysis isn't completely died out, but it's very rarely used. Like I can't find a psychoanalysis. I know one professor who practices psychoanalysis, and that's Dr. Perkins. But I think he does mostly hypnotism and he does dream analysis interpretations. That's all I know about it. But I do know it's very hard to find someone who follows that life path in their practices. Most people follow this path, the cognitive therapies. At least that's where I come from. My background is cognitive behavioral therapy. Okay? So cognitive therapy is often called cognitive behavioral therapy. Approaches to therapy that are based on the premise that most behavioral disorders result from distortions in cognitions or thoughts. Okay, so instead of Freud's theory in psychoanalysis stating that our thoughts or our unconscious mind causes our disordered thoughts, it's our thoughts itself. We have to change the thoughts or how the person thinks in order to get that person to heal. So disordered thoughts cause disordered behavior. So I used to ask my students all the time, where do feelings come from? They come from your thoughts, okay? Feelings come from thoughts. Unless it's a knee-jerk reaction, like a jump scare reaction or any reaction to shocking events. Most feelings come from thoughts. So the therapists, now this is called psychotherapist. Most people get confused by this. Any person who practices talk therapy is called a psychotherapist. Okay? So psychotherapists that practice this theory, cognitive therapy, attempt to demonstrate to their clients how their distorted or irrational thoughts contribute to their behavioral difficulties. So if I get upset easily, okay, that's probably because I have a problematic core belief or thought pattern that causes me to interpret the situation differently from someone else. Rational emotive therapy, RET, is an approach to therapy based on the premise that psychological problems result when people interpret their experiences based on self-defeating irrational beliefs. Excuse me, guys. Okay, guys, I'm back. Sorry about that. It was fun. I had to make sure my dog had food. Okay, so there's two different types of cognitive therapies or cognitive behavioral therapies we will talk about today. First one is rational emotive therapy. So this goes on the same path. They say thoughts create feelings, feelings create behavior, and behavior reinforces thoughts, and the thoughts create the feelings again. This RET therapy is based on the approach therapy on the premise that the psychological problems result when people interpret their experiences based on self-defeating irrational beliefs. So these irrational beliefs could be anything. I'm going to talk to you guys about some interesting ones you could have. An irrational belief or a core belief could be something along the lines of everyone has to like me in order for me to feel like I'm worthy as a person. I have to be liked in order to feel worthy. Now, there are people out there who don't like Mother Teresa. There are people out there who don't like Gandhi. And admittedly, those people had dark sides, but which I won't go into here. We can talk about that later if you like. But everyone has. You can be the nicest person in the world, and still not gonna be someone who likes you. That's considered an irrational belief. Hey, Erza. Erza, want to say hi to my students? Come, want to say hi? Hey guys, this is my dog. Hi guys, how you doing? She wants to say hi to you this morning. But she wants to say hi to a pug today. So they believe that these singular thoughts, or it could be you have a bunch of irrational beliefs. How we interpret those things, we interpret our experience based on those beliefs, we're going to be miserable. So, or we're not going to live up to our full potential. So RT therapists help people find flaws in their thinking, then challenge or dispute these maladaptive cognitions. You said this, do you believe this? And they would try to challenge that and guide them to substitute more logical or realistic thoughts. So you substitute these maladaptive thoughts with more adaptive ones. If some people don't like me, that's okay. I'm not responsible for what other people think of me. Honestly, that's true. You're not responsible for it. This helps clients get better by increasing their feeling of self-worth and removing stumbling blocks to personal growth. So you want to try to get rid of these irrational thoughts, because irrational thoughts can cloud your mind, can make life harder. It can make it harder for you to live, a normal, healthy, fulfilling life. Let's talk about cognitive restructuring therapy. That's Beck. Cognitive, let me see. Rational motive therapy, what I just covered about the irrational thoughts thing, that is by Albert Ellis. He had a very confrontational viewpoint here. Very confrontational viewpoint. So Beck, on the other hand, for cognitive restructuring therapy, he was aimed at restructuring irrational thinking patterns, not individual thoughts, but irrational thinking patterns, such as the tendency to use negative self-labels. So he believed that people who don't value themselves have a tendency to overgeneralize from their experiences and unconsciously seek out other experiences that will confirm to their poor self-image. So without knowing it, let's say if I keep trying to hang out with the same type of person and I keep getting rejected, but I keep going back to that, and it's going to reinforce my poor self-image, like, oh, I'm unlovable. So the therapist and client make a list of misguided self-impressions and agree to some experiments to test these assumptions. Now you can talk about thought experiments. What if this happened? How would you feel if this happened? So let's evaluate these cognitive therapies, this cognitive restructuring therapy and rational emotive therapy. Research suggests that for some behavioral disorders, cognitive therapy can be quite effective, especially for treatment of depression. Okay? There's been much debate about whether these positive effects are from the cognitive or the behavioral piece. We don't know. Is it because we're looking at how thoughts affect behavior, or is it because we're looking at how maladaptive thoughts form? Which part matters? We're not sure. But we do know that it's important to address the feelings between both. Now, I'm not going to lie to you guys, different forms of therapy have different results, okay? Different forms of therapy are good for different things, and they all have different philosophies underlying them. They're all valid. They all work for some people. But not everything works for everybody. Okay, so psychoanalysis won't work for someone who's heavily schizophrenic, someone who has a severe dose of schizophrenia, someone who has advanced stages. Okay, cognitive behavioral therapies won't work that well for that sort of person. Let's talk about behavior therapy. Okay, behavior therapy focuses on the behavior itself, not how the thoughts that cause behavior, but the behavioral therapy. Therapy is based on the assumption that maladaptive behavior has been learned and therefore can be unlearned. We learn bad behaviors the same way we learn good behaviors, right? We learn bad behaviors the same way we learn good behaviors. So if we're trained to engage in a bad behavior, we can be trained to engage in good behaviors too. So maladaptive or more adaptive behaviors anyway. I used to work in an autism clinic. When I was about 24. It was called Therapy Center of Acadiana. Very, very good place to intern. But I've noticed that we were trying to respond differently to our clients' needs to get attention. They did terrible things to get attention, or they did bad, or maladaptive things to get access to something that they wanted. So we're going back to chapter 3. We're going to do a rewind to chapter 3 right about now, and we're going to talk about reinforcement, punishment, classical conditioning, and operant conditioning. So classical conditioning is going to involve basically forming associations, okay? And operant conditioning is going to involve reinforcement and punishment. So everything involves associations, but we're trying to figure out, does it have something to do with being associated with something the person doesn't like? Or is it because we're trying to train their behaviors by by teaching them maladaptive or undesirable results will occur if they do something bad? So we can kind of try to train good behaviors into people through reinforcement and punishment. And we can treat things that are more automatic with classical conditioning. So we're focusing on the person's behaviors being the source of the problem, not their thoughts, not their unconscious mind, but their behavior. So trying to identify underlying personalities, repressed conflicts, and unconscious motives that are causing the maladaptive behavior. That's another forms of psychotherapy. We're just talking about behavior here, okay? Behavioral therapy is just focused on behavior. It's the only thing we care about. We know that thoughts exist, but most behaviorists believe that thoughts are irrelevant. And I have a strong behaviorist background. So I think that reinforcement, punishment, we need to focus on the behavior itself. Okay? Excuse me, my dog's just reverse sneezing. Ugh. Let's first talk about Pavlovian conditioning therapies. Now, what do we learn about Pavlovian or classical conditioning? We associate one stimulus with another stimulus. Okay? Little Albert, he learned to be afraid of what? Everything that's white and fuzzy. Because he associates something that's white and fuzzy with a big loud noise. Okay? Why the dogs learn to salivate at a bell in Pavlov's study? Because they associated the bell with food. I'm not going to try that on my dog. Any behavior therapy that involves Pavlovian conditioning, for example, systematic desensitization therapy. This is used in the treatment of phobias. Now, why do we have a phobia? You're probably wondering about my thing with butterflies, right? Most people are like, well, why is Miss Frederick afraid of butterflies? I have what is known as lepidopterophobia. I don't like any big winged insects. God forbid one gets in my house. I wake the neighbors. I noticed that it's because I associate the bug with a feared stimulus. Okay? Same way, some people are afraid of things like dogs or rats. Personally, I think rats are adorable. But I mean, that's only if they're like well trained. So being so afraid of a snake that you want to burn your whole house down if one enters your house, that would be considered a phobia, especially if the snake is essentially harmless. Okay? So what are things about being afraid of the dark? That's a big phobia, and also it's very maladaptive. A person who's afraid of the dark because of a particularly frightening experience as a child would pair that experience with the dark. Okay? So these two things have been associated, right? Maybe they were attacked, maybe someone scared them. We know repeated exposures to darkness without the association of a frightening experience would eventually cause a conditioned fear response to extinguish. Okay? So what happens if what I'm basically saying right now is what happens if you're afraid of the dark, but you're put in the dark several times after that and nothing happens? Would you be cured? No, it's actually more complicated than that. I would have to systematically desensitize you to this dark. Okay? I'd have to work that out of you slowly but surely. And this does work for things like lepidopterophobia as well, fear of butterflies or big winged insects. So eventually, over time, gradual exposure to the feared stimulus with a relaxing environment would eventually cause it to go away with a lot of work, and sometimes it takes a long time. So if we pair something with a feared stimulus, you can also pair it with a relaxing stimulus as well. Okay? So behavioral therapy that pairs a slow systematic exposure to anxiety-inducing situations with relaxation training. That's what systematic desensitization is. So in order for it to work, you have to first analyze the problem carefully. In what situation does this fear show up? I noticed that I was walking down the street to my mailbox the other day, and I was wearing the face masks. I'll show you. Watch, ready? This is my face mask. Now, I was wearing this mask when I went outside the other day, and a butterfly swooped itself in front of me, and I was like, oh, I didn't move. I didn't run. It's like, huh. Why am I in a better state right now? Because I don't like the idea of a big winged insect going anywhere near my face. But once I had this on, I was less afraid. I don't understand how healthcare workers can wear this all the time. I'm trying to breathe through this sucker. It's not easy. Okay, so if I were to realize, okay, this is what I'm afraid of, I would be able to develop a strategy to know how to deal with it, right? So we analyze the problem carefully, do this relaxation training, and we confront the anxiety-producing stimuli in the real world. So we start from something small to gradual, closer exposures to the real thing. This is very good in dealing with specific fears and anxieties such as phobias. Okay, so let's say Miss Mary Sue's afraid of the dark. Okay, she's afraid of the dark, doesn't know how to deal with it, so she just avoids going out at night whatsoever. So what will happen at first is that the therapist might put her in a dark room with some relaxing sounds and music, maybe have someone stay with her, and eventually put her in there alone. Maybe an eventual goal would be to gradually expose her so she can walk outside in the dark by herself without panicking. Now, I'm not exactly sure how they would do that, but they'll gradually expose her to the dark. Not just right away. See, if you were to throw me into an insectarium, or to throw someone who's afraid of the dark, I think it's called nyctophobia, into a completely dark room by themselves with no idea how to get out, both those situations are known as flooding. That's not systematic desensitization. You do not want to do that to someone because it's going to make it worse. You have to gradually expose it. You got to slowly draw the negative association out. It's not going to happen overnight. Not going to happen in one day. Probably going to happen in a period of weeks or months. So how can we utilize this for other real-world problems? I'm going to give you an example of virtual reality therapy. This has been around for a hot minute, but now the people in their homes are starting to become more exposed to this. Because I don't know if you guys noticed, but there's VR goggles going around since 2016. They're super fun. So patients sometimes find it difficult to imagine frightening or anxiety-provoking scenes. So if you have a hard time dealing with things that are anxiety-provoking or frightening, virtual reality therapy is a good way of dealing with it. And honestly, that's the best way, you know? So there are people out there who have been in combat situations or who have been assaulted, and they experience something known as PTSD. How do you deal with that? Well, you gradually expose them to the feared stimulus. This is utilization of virtual reality simulations to create a variety of stimuli for systematic desensitization. Okay? So you use this virtual reality simulation. It could be, let's say your caravan was attacked, or your tank was attacked in the Middle East, in the desert. In order to deal with that, you would put someone in the desert, but like not expose them to any feared stimulus other than that, so you wouldn't be afraid of it anymore. And you kind of pair that with a relaxation technique. I'm not sure exactly how they do it, but I would love to do more research and find out. Virtual reality therapy has been used successfully to treat a range of substance abuse, depression, and anxiety. So they call this is still Pavlovian conditioning we're talking about, because we're talking about associating something that you're afraid of with something calming, instead of with the feared stimulus in the first place that caused you to react. Okay. Let's talk about aversive conditioning. Quite possibly my favorite topic in this chapter. Aversive conditioning the goal is to condition an aversion to some specific stimulus, such as inappropriate sexual stimuli, alcohol, or cigarettes. So y'all know those things like being attracted to things that are inappropriate is something that probably needs to be fixed, and fast, if you notice you have it. or being attracted to things like alcohol to excess, to the point where you use it to treat all your problems. Some people treat that by taking a pill, and when you get tempted to have a drink, you take the drink, and the drink makes you throw up immediately. And thenceforth, you don't want that drink again, or you don't want alcohol for a long time. So it says in the slides, an alcoholic's behavior is normally characterized by excessive attraction to alcoholic drinks. If given a drug that causes nausea and vomiting when combined with alcohol, it won't take many instances before the alcohol begins to elicit an aversion response. And also, you guys, remember how we talked about conditioned taste aversion? How I ate celery once and made me sick because I ate too much of it, and now I can't eat celery anymore, which is a tragedy and a travesty because I used to love celery. But in this case, you take a pill, the drink makes you sick, so you're not gonna want that drink anymore. I don't care how strong your attraction to alcohol is. A human's desire to avoid nauseating circumstances is pretty strong. So you're probably wondering, well, Miss Frederick, I mean, if I drink and I get hungover and I throw up a lot the day after, how come that doesn't happen to me already? Well, that's quite simple. Because if you take a drink and you're hungover the next day, the it happens within a long enough time so the association isn't formed, you see. So what happens is if I get drunk and then I throw up the next day, that's the next day. It doesn't happen immediately afterwards. If I take that pill I talked about, it makes you throw up immediately after I take the alcohol. The association is formed because I have that immediate aversive response. So if it happens right away, the association is formed. If it happens the next day, that association ain't going to be formed. The same way if I ring a bell and feed a dog an hour later, the dog ain't going to care about the bell next time I ring it. Hopefully that's well explained. I hope you got that. So basically, it's also used to treat things like pedophilia. I'm not going to mention that on a YouTube clip as how they treat pedophilia, but basically they associate stimuli with children with an aversive stimulus. I'm not going to say which one it is, but show them a picture of a kid if you're a pedophile and they shock you. And so you pair the shock with the attraction, you would no longer be attracted to that person anymore, hopefully, with repeated trials that'll work. That's considered inappropriate sexual stimuli. It did also work for, I think at one point they did it for people who were people who were gay or bi or on the LGBTQ spectrum. At one point it was considered illegal to be gay or exhibit gay behavior in any way, shape, or form. So the best case scenario would be to give them hormone supplements in order to curb that behavior, which in many cases killed the person. So they don't teach you that in school, but I learned that. So basically, you need to be aware that conditioned aversion is often highly resistant to extinction. So they give you aversive conditioning as a way to stop your attraction to this undesirable thing like cigarettes or alcohol or pedophilia. They want to reduce that behavior, sharply curtail it. They give you something that's going to make you throw up or make you sick. And admittedly, I've only heard about this being done once, but I know that's a part of the treatment. So hopefully you understand that. So you pair something undesirable with something aversive to the person, hopefully over a brief period of time, that a new association is going to be formed to replace the old one. So aversive conditioning has been used successfully to treat sexual offenders and deviant sexual behaviors by conditioning an aversion to inappropriate sexual images, such as underage children in this case, and promote normal sexual arousal to appropriate sexual stimuli. So in this case, you pair a picture of a child or an image with a shock. And that's pretty much how it works. I'm not going to explain exactly how it works because I don't want to gross you guys out, but that's essentially how that works. So systematic desensitization and aversive conditioning are both types of classical or Pavlovian conditioning. Okay, we associate two stimuli together to form the association. With operant conditioning therapies, which is probably going to be the one you're more familiar with because you use it every single day, we associate a behavior and a response. Okay? This behavioral modification technique is an attempt to influence behavior by manipulating reinforcers. The best one, it's easier to reinforce good behavior than it is to punish bad ones. So positive reinforcement is a technique that's based on the fact that people behave in ways that produce positive consequences or reinforcers, right? So sometimes we reinforce people for the wrong behavior. Imagine someone's bugging you in class trying to get you to give them their notes because they don't want to show up to class. Try to get you to give them their notes. Hey, give me your notes, give me your notes. I didn't show up to class. If you give them your notes, then you're reinforcing that behavior, aren't you? So you don't want to do that. So you're positively reinforcing them in that case by giving them what they want. Okay? This approach to therapy involves identifying desired behaviors, determining one or more reinforcers, and providing reinforcers contingent upon the client's engagement in that desired behavior. I'm going to go back to my therapy center of Acadiana example. We did something known as errorless learning, where someone made a mistake, they wouldn't get punished or anything, they just wouldn't get a reinforcer. We work with kids from really, really young age to much older. It's also a powerful tool for shaping behaviors. Teachers do this all the time. If I can tell a student's behaving properly, I'll give them a small amount of reinforcement. And then we'll move on from there. But if it's something that takes a lot of effort, you give them more reinforcement. Let's say if an autistic child speaks for the first time, the first thing you need to do is reinforce that kid. Okay? Because most kids with autism are non-verbal. Then, of course, there is punishment. Okay? This is an aversive stimuli that can be used to punish disordered or self-injurious behaviors. These are things that people do, on purpose. Whereas things like sexual attraction, alcoholism, things like that, those are often things that a person engages in without a lot of effort. So if someone speeds and they get a ticket, that's not therapy, that's just the justice system, but it affects them hopefully helps reduce that behavior. In the slide that says a 9-month infant developed a chronic pattern of vomiting and regurgitating food. You deliver a small electrical shock to the leg that was immediately effective in reducing vomiting. After a few short sessions, the vomiting would cease. Yeah, I'm not really in the habit of shocking babies, but I guess in this extreme situation that might work. I don't know. So electric shocks have been used to effectively eliminate head banging, biting, and severe scratching in young children. So basically, if you're in a situation where your life is threatened anyway because of your bad behavior, I suppose in that case the shocking might work. So punishment is whenever you pair an undesirable behavior with a challenging consequence, with a aversive consequence. So if you're going to teach a kid good behavior, you have to model that behavior first. A parent can't always expect their kids not to cuss if they cuss around their kids themselves. So, and same thing with teachers. I mean, I can't expect students not to cuss in class if I cuss in class myself. So modeling can be a helpful therapy technique for extinguishing irrational fears or new, more adaptive behavior. For example, someone who's deathly afraid of the dark would be useful for them to observe others entering the dark with no visible adverse effects. Okay, so if you're afraid of the dark and someone else just walks in the dark by themselves and they're okay, it might encourage you to do it too. When I was a kid, I was afraid of jumping out of trees, and my friends and I used to climb trees, and I was afraid of jumping, but everyone else jumped out of a tree without any fear, so I'm like, okay, I'm gonna do it, and I jump. So it made all the difference, really. Having other people do something without fear of doing it. Modeling can be live or take place through films or videos. So I'm sure you guys like to watch makeup tutorials online, or for those of you guys who are gamers, you like to watch gameplay online or let's plays. I remember Andrew saying something on the lines of he likes to watch fishing videos or something like that, or hunting videos, and he learns how to do certain things by watching those videos. So those are all ways you can learn step-by-step techniques. But you can also look at modeling for difficult situations by watching videos. For example, I used to do this with my clients. There is a internet show called Charisma on Command, where they show how different characters or different actors deal with difficult situations and how they look really good doing it because they train themselves in how to maintain charismatic behavior. But you see examples on how to deal with that by watching these videos. So you combine these things with relaxation training. It's also good for teaching people social behaviors or assertiveness techniques. So if you watch somebody else doing it, you're more likely to do it yourself, but you have to have a role model show you how to do it. Otherwise, you're not going to learn. So modeling normally occurs first. Let's evaluate these behavioral therapies. This is going to be a test question, so I want you to know this. The majority of cases are being treated by behavioral therapies, okay? It has the broadest range of treatment options, and it's actually the most effective for the widest range of behavioral disorders. So it's used to treat people with eating disorders or body dysmorphia, self-injurious behaviors like cutting, addictions, and deviant sexual behaviors, including phobias as well. So if appropriate changes are not occurring immediately, the approach can be easily identified or modified. So let's say if I'm working with someone in the dark and if I'm trying to help them get over their nyctophobia, I think it's called, and I put them outside in the dark all at once, they freak out. I'm like, okay, well, that's not working. You can tell what's easily not working. You can modify it based on what isn't working. So if you take data on someone's behavior, it makes it really easy to track and see what's going wrong, and how you can modify your program to help the person get over their fear, or help the person stop, throwing up after meals, or whatever it is you need the person to stop or start doing. So you can change the program and you can see what obviously is not working. Oh, the person's numbers are down this week. I want to know maybe I can change something. So behavioral therapies are based upon well-defined and understood principles of human and animal learning and behavior. So these are things that we have done a lot of research on, things that we have empirically tested. So if we do a behavioral analysis technique on someone, we know it works because we have tested on other people before. Unlike Freud's theories, which have not been empirically tested as much, but we know that cognitive behavioral therapies have been tested. So behavioral therapies are probably a very good investment if you suffer from something like autism or body dysmorphia or an eating disorder. Behavioral therapies it's going to be something that's going to be used in your treatment program. Another thing I didn't mention is something known as the token economy. That's something that people use in a lot of mental health situations, where you can earn tokens for how well you act. That was very common in Therapy Center of Acadiana. Kids have this little plate of tokens where you can put like a little Velcro token on it. And when they want to do something, we'd make them pay us with the tokens that they'd earn on the plate. But they have to get the entire plate full of tokens before they got to do what they wanted, which most of the time was playing with an iPad or playing outside or playing in the playroom. So if a child did what I wanted for them 8 times, or let's say they did something really difficult and did enough times, we would then who then eventually, let's say they had to fill up 8 on their little tray, they would give it to us, give the little stickers to us, and they would go and they would do what they wanted after that. So that's token economy, is using these things as tokens. The same thing with money, isn't it? Isn't money a token economy? Because we do certain amounts of work and we get a certain paycheck at the end of it. This is slightly different, where the child or the person in therapy does a certain amount of things, and when that when they earn enough, they get what they want. Same way you could save up for like a really good car, a really good piece of equipment. We're kind of living in a token economy right now. But some people who made certain milestones in their therapy might get certain like sundry store bucks where they can go and they can purchase what they want. That's another type of therapy. That's a form of token economy that's used in therapy a lot. Let's move on to biologically based therapies. Now, while psychotherapy mostly focuses on talking and it's very non-invasive for the most part, biologically based therapies talk about things like ECTs, electroconvulsive therapies, magnetic resonance imaging therapies, and psychotherapy, including drugs. So sometimes psychotherapy isn't enough to treat more individuals with more severe behavioral disorders like schizophrenia, bipolar disorder, bipolar 1 or 2, extreme instances of anxiety and depression. In these cases, drug therapy in addition to psychotherapy is needed. Only clinicians with medical degrees may use biomedical treatments. Okay, so I'm going to explain to you how this works right quick. Psychiatrists are people who they actually go to med school. Okay, now in the U.S. in Louisiana, it is possible for you to get your degree in clinical psychology, see clients, and then proceed to get a separate license to prescribe medication, but most people just choose to go to med school. It seems easier for them. So only clients with medical degrees may use biomedical therapy. So psychologists who often refer clients to a psychiatrist or other medical practitioner when biomedical treatment is necessary. So say I think you benefit from anti-anxiety medication. Here, why don't I write a prescription, or I can have this person who's a psychiatric nurse write a prescription for you. Because a lot of times therapists will have prescribing individuals on hand who can sign off on the prescriptions. Doesn't necessarily have to be a psychiatrist. Sometimes it could be a clinical psychologist or a psychiatric nurse. Because I know when I was getting Vyvanse, it was a psychiatric nurse. So psychosurgery is one type, and the earliest form of biomedical therapies. Because I don't know if you guys know this, but trepanation used to be regularly practiced at one point. It's when someone drills a hole in a person's head in order to release the evil spirits that reside in the person's head. So, yeah. But in the early days, I think it's mostly Cro-Magnon times when that happened, they didn't realize that mostly killed the person. Trepanation, drilling a hole in the head, normally kills an individual. And it's not a nice way to die either. So we found other ways over time to treat mental illnesses and relieve the pain for the person without risking killing them. So mental health hospitals essentially were warehouses for people with behavioral disorders. Once you got in there, you had no rights. You couldn't really sign yourself out very easily unless someone recommended it. So a number of psychiatrists began experimenting with biological interventions because a lot of people went into the mental health facilities, but it was really hard to get in there. It was really easy to get in there and really hard to get out. Kind of like prison is today. Really easy to get into, really hard to get out, depending upon, what the situation is. So Antonio Dieguez Muniz learned about chimpanzees who had prefrontal cortexes removed, which abolished violent outbursts, because chimpanzees are probably more prone to schizophrenia than any other ape. So in order to deal with that, they severed the path to the limbic system. The limbic system is the part of the brain that produces emotions. So Moniz persuaded a colleague to experiment with surgery on the frontal lobes of people with schizophrenia and other severely disturbed patients. How much good do you think that did? Not as much as it should. So they started forming something known as lobotomies. Lobotomy refers to a sort of psychosurgery that severs the nerve tracts between the frontal lobe and the limbic system. This is a surgical procedure that severs the nerve tracts connecting the prefrontal cortex to lower brain areas that mediate emotional responses. Things like the amygdala and the prefrontal cortex, which is up here. So by severing that, you made the patient easier to deal with. So a hole was drilled through the skull on each side of the head, and a blunt instrument was inserted and rotated. I know, I haven't eaten breakfast yet, and I think I'm going to regret that. So transorbital lobotomy is an ice pick-like instrument called a leucotome. Was inserted through the brain through an eye socket and rotated back and forth. So right there. At that point, the nerve tract between the brain, the prefrontal cortex was severed. And with most forms of brain surgery, it's kind of hard to get that back. So granted, guys, this began in the 30s, essentially. So let's check to make sure my math is right here. And it happened mostly in the 30s. So you see a lot of jokes about it, but it was much more common back then. Lobotomies became very popular for treatment with schizophrenia and calming severely disturbed patients. Here's the problem with that, though. 40,000 people were recipients of this surgical intervention. Problem was, after the lobotomy was had or the surgery was underway, the person couldn't take care of themselves. Because without access to our emotions, it's almost impossible to make decisions, because every decision you make has a somatic marker on it. So if you can't make that emotional decision, it's just hard to live your life without access to your emotions. So these people were essentially in a vegetative state. They were easier to deal with in the hospital, but it was harder for them to exist on their own. The ultimate goal of any hospital is to get people out the door, okay, to heal them. So while lobotomized patients seem more calm after the operation and more manageable, it also turned them vegetative. So improvements have been exaggerated. They're like, oh man, Moniz, you're such a great dude. No. There was high rates of recidivism in the hospitals. They would let them out, but they would put them back in because they couldn't live on their own. Some turn lethargic, unmotivated, and robot-like. There's also memory loss, inability to plan ahead, seizures, and even death. Oh, gee, that's what happens when people experience brain damage. Who knew? And I'm mocking them because I have a modern perspective on this, but at that point, I'm sure that was all they had. But at the same time, it's like they didn't consider the benefit of the client in that situation. So I'm disgusted at my forebears. Let's talk about another type of form of psychosurgery. There are newer procedures being used instead of lobotomies. Nowadays, brain lesions created with radio waves are being used to successfully treat patients with severe OCD when other treatments have failed. So it's used to successfully treat patients with severe OCD when other treatments have failed. So these newer treatments are being used, basically. Hopefully we're not doing lobotomies anymore, because that did not work. Let's talk about ECTs and magnetic seizure therapies. You guys have heard of electroconvulsive therapy, I'm sure, because it's something you've seen in the media, something you've seen in movies and things like that. And yes, it is still used. It's used in the last minute resort, but it's much better now. So Laszlo Meduna knows that patients often experience a remission or lessening of symptoms after they experience a seizure. So he began to experiment with creating seizure-like convulsions. Oh yeah, they shocked a person's brain. This is a method, the ECT, electroconvulsive therapy, is a method to induce seizures by strong electrical current applied to the brain used to treat depression. It can also be used to treat some forms of psychosis. But if I'm dealing with that nowadays, it's very localized. At one point they put on both sides of the person's head. Sorry, I'm too squeamish to be teaching this chapter. But they put on both sides of the person's head and then shock the person and make it very difficult for there was of course side effects to it. It was used to treat depression. Nowadays, it's more localized to put on one side of the brain or near the area that need to be shocked or stimulated. And yes, ECTs are still being used normally when medications have failed. So there's that. It is a godsend for some. So magnetic seizure therapy is a method of inducing seizures using strong magnetic fields as opposed to electrical currents. Used to treat depression, bipolar disorder, and schizophrenia. Okay? Magnetic seizure therapy is using magnetic fields rather than electrical shocks. I would imagine it would be less painful. I've never experienced it myself. So he noticed, the person who came up with this noticed that symptoms of behavioral disorders often reduced, but patients experienced painful spasms, uncontrollable convulsions that sometimes resulted in fractures or even death. Again, there's always risk when it comes to surgeries like that. Several modifications have been introduced to make this treatment safer and more humane. First, for instance, like if someone's going to shock my brain, I'd hope that they put me to sleep first. They give me some sort of muscle relaxant. Guys, I'm just going to be honest about myself. I can't even get my teeth pulled or go under any sort of nitric gas without being given some sort of muscle relaxant. I had panic attacks under nitric gas. So I need to be given a muscle relaxant in order to deal with it. So in this specific case, they are put to sleep. Like they're given like some sort of anesthesia and put to sleep and muscle relaxants before the shock is delivered. So it's less traumatizing and involves less collateral damage. This is used with patients with depression, bipolar, in some cases schizophrenia. So what happens is it works by increasing the availability of norepinephrine and serotonin. If someone has someone has depression, their brain does not produce enough serotonin and does not distribute it well enough in order for their moods to be regulated properly. So without enough serotonin in the brain, a person does experience a form of depression. In norepinephrine. So then there's deep brain stimulation. This is something I know the least about, I'm not going to lie. This is an invasive procedure when an electrode is implanted deep in the brain and electrical current can be applied periodically. It can be adjusted by remote control. It can be used to treat Parkinson's disease as well as depression, bipolar, and OCD, and it does, like ECT and magnetic resonance therapy does, it increases neurotransmitter release, which is what you want. In situations like bipolar, depression, things like that, your brain is producing too much or too little of these neurotransmitters. So your brain is not getting the chemical messengers it needs, and yes, there are going to be a behavioral side effect when it comes to that. So you need to treat the neurotransmitters. Psychoactive drugs. Now this is probably the most popular form of biologically based psychotherapy. Okay? Since the 1950s, therapy with psychoactive drugs has become by far the most common form of treatment for psychological disorders. So it got people out of out of institutions, which is what you want. Okay, it got people to live on their own, independently. It may not be a perfect life, but it's better than people telling you when to go to the bathroom, essentially. So, psychoactive drugs are drugs that have the effect of altering mood and behavior by changing neuronal functioning. They have contributed to a decrease in the number of people hospitalized for behavioral disorders, along with a decrease in the length of stay of hospitalization. So about 60% of the U.S. population will take some form of psychoactive medication in their lifetime. Some form of it. 60%. Might be taking stimulants for a while, they might be taking antidepressants for a while, they might be taking whichever. There's 5 different types of psychoactive drugs. The first one and the first made is antipsychotics. An antipsychotic is a drug used to treat psychotic disorders such as schizophrenia. Psychosis means you have a break from reality. You see or hear things, or you experience thoughts that aren't based in reality, or you see or hear things that are not there. Now, you can experience hallucinations with any of the 5 senses. You can hallucinate touch, smell, hearing, sight, and taste. I don't know why I forgot that. So, that's considered a hallucination. When you perceive something isn't there, and delusions is when your thoughts are not grounded in reality. So, in this case, there's not much you can do from the psychotherapy standpoint. You can work with a person, but they're going to need some sort of medical intervention, as this is such a biologically based disorder. Schizophrenia has very high concordance rates in the family. Okay, it's very genetically based. So if your mom has it, you have like a 70% likelihood of getting it. If your twin has it, you have an over 95% likelihood of getting it. So it's a very genetically based disorder. So you need an antipsychotic. You need a way to reduce responsiveness to irrelevant stimuli. Okay? So the first wave of antipsychotic medicines, okay, were called atypicals. So they're called typicals. Okay? So if you have a form of psychosis, that means you have too much dopamine in your brain. So these antipsychotic drugs work by blocking dopamine receptor sites. They prevent an excess of dopamine from being passed on from one neuron to another. So 40% of the patients from the typical antipsychotics, specifically Thorazine, which was developed in the 50s, had a serious side effect called tardive dyskinesia. Tardive dyskinesia. I'll say it again because most people get this wrong. It won't be a test question, I just want you to know. This is known as uncontrollable muscular movements of the jaw, lips, and tongue, something like that, and range from barely noticeable chewing motions to involuntary biting of the tongue, along with severe motor disturbances. So, yeah, it made it a little harder to live with that, you know. So later on, they developed something known as atypical antipsychotics, things like Seroquel and whatnot. And it's used to essentially treat people without the major amounts of side effects. So that way you're able to deal with your hallucinations without necessarily having to be institutionalized or have all these crazy side effects. Next is antidepressants. You've probably heard of these the most, right? Like you've probably heard of SSRIs or SNRIs. You've heard of things like Prozac and Paxil, right? The effects are very effective in lifting the spirits of severely depressed people. These include tricyclics, MAOIs, monoamine oxidase inhibitors, and SSRIs, which is selective serotonin reuptake inhibitors. Now, these drugs increase norepinephrine and serotonin. So what happens is if you don't have enough serotonin, yes, you will experience feelings of depression, along with increasing expression of essential neuronal growth proteins, such as trying to reverse the cell losses associated with depression. So, SSRIs, including Prozac and Paxil, are currently the most widely prescribed, with over 10 million people worldwide taking them. Unfortunately, these drugs are associated with sexual dysfunction, sedation, and weight gain. So if you can take an SSRIs, you do have the lowest amount of side effects, but again, it all depends upon how your meds affect you, you know? So what happens is the medicine disengages the brakes in the neurons, and it blocks the serotonin from going back into the cell. And you want the serotonin to remain available for usage. And there's anti-manic medication, such as lithium. This is designed to treat the manic symptoms of bipolar disorder, because I mentioned before how mania can be often very detrimental to a person. The manic and hypomanic symptoms of bipolar disorder. Things like lithium carbonate is a simple organic salt, has been the most effective drug for controlling the manic symptoms of bipolar disorder. It does leave some people from feeling dead, though. That's what I'm hearing. And it also reduces the depression associated with it. So it kind of levels you out. It's known as a mood stabilizer or an anti-manic. So it reduces the frequency and severity of manic episodes and sometimes prevents them altogether. These drugs work by increasing activity of serotonin and increasing production of neuronal growth proteins. So if you don't have enough serotonin, again, it will give you issues in your mood. Anxiolytic drugs are used to treat anxiety. Again, you might be more familiar with these, like Valium and Xanax. These are used to reduce symptoms of anxiety and promote sleep. They're often considered sleeping pills. They're useful in reducing the symptoms of generalized anxiety disorders, panic disorders, and some sleep disorders. There's two major categories, barbiturates and benzodiazepines. Now, benzodiazepines are more, benzodiazepines are less toxic than barbiturates are. Okay? Barbiturates work by increasing GABA, gamma-aminobutyric acid. That is a neurotransmitter in the brain designed to calm you down when you get anxious. Okay? It's considered an inhibitory neurotransmitter. If you do not have enough of gamma-aminobutyric acid or GABA, you do not have enough of this, it can cause you to have things like panic attacks, or it can cause you to have generalized anxiety disorder. It's difficult. So basically, barbiturates are more dangerous. Overdose with barbiturates are often lethal. And please, sweet Lord, promise me that you will never ever take a medication with alcohol. Like, especially not an anxiolytic drug. Like, don't take Xanax with vodka or beer. That'll kill you. Don't do it. But I know some people who tried and don't do it. It's stupid. Okay? So, again, I'm normally not one to judge, but just, guys, don't die. Okay? It's just not the best thing you can do for yourself. So, again, overdose is often lethal with barbiturates. When people stop taking barbiturates, they have severe withdrawals and produce tremors, convulsions, and severe anxiety. So most people don't like to use barbiturates. They prefer to use benzodiazepines. Benzodiazepines work like barbiturates, but are far less toxic. Most common forms are Valium and Xanax. These meds, along with newer sleep meds, like Ambien and Lunesta, increase GABA as well. So the idea is if you're having anxiety frequently, you want to increase the availability of GABA. You want that because it'll help inhibit these feelings. One of the most common remedies for anxiety and sleep problems can be found in health food stores, such as Valeriana officinalis. Says it's shown that its extracts were as effective as Valium in reducing anxiety. It also works by increasing GABA. It works by increasing GABA. So basically, some people like over-the-counter sleep aids. Some people like it, in different ways. So you're probably wondering why I call anxiolytic drugs sleep aids. It's because anxiety does definitely affect the way you sleep. So it kind of works hand in hand that way. At last, I have stimulants. I do have experience taking these. I've never taken any other type of psychoactive drug before. So I have tried Vyvanse. I refuse to touch Adderall. Refuse. These are drugs used to treat attention disorders and narcolepsy. Okay? It's effective in increasing attention, focus, concentration, and alertness. So you're probably wondering, well, Ms. Frederick, why don't you want to take Adderall? Because it's basically meth. It's probably not the exact same, but it's might be cut differently or something. I'm not exactly sure how it is, but it's the basic same chemical composition. And I know it can be very addictive for some people, which is one of the reasons why I would prefer not to mess with it. Again, there's Adderall, Vyvanse, and Dexedrine. I have very little experience with Dexedrine, but I'm thinking about asking my doctor about it. Adderall is a quick release. You take it and it affects you kind of all at once. Vyvanse is a slow release pill that releases slowly throughout the day, so it's considered more mild. So again, it works by increasing dopamine, which is associated with pleasure, motivation, and attention. So some people report feeling really, really good when they're on it. Explains why I feel really, really good after I drink an entire carafe of coffee. If I drink that much coffee, I promise you, I ain't going to be feeling sad for a long time. But it works in a similar way. I notice my symptoms of ADHD gets much better after I've had some coffee. But again, that doesn't substitute a good night's sleep. So common side effects of these drugs include irritability, decrease in appetite, disturbed sleep patterns, and seizures from high doses. So again, don't be taking your friend's stimulants, okay? Talk to your doctor. Be aware of medication interactions. I swear to God, this can only help you. Please, I'm begging you guys, don't be taking medication from your friends because you don't know how it might be affecting you. Your body might not be able to handle Adderall. Some people take Adderall and they're fine. Okay? Some people take Adderall and they're fine. But not everyone. So again, like be aware of your family history, talk to your doctor, kind of talk to the doctor about side effects. Don't be afraid to come to your doctor with questions because they should be ready to answer those questions. Okay? And honestly, if you feel like a drug is affecting you poorly, tell your doctor whenever you can. Okay? Because your doctor's opinion is way more valuable than mine. But seriously, for a lot of this stuff, if you're interested in taking some sort of drug, don't just take my word for it. Like, talk to your doctor. Get to a walk-in clinic and say, hey, I'm thinking about this and this. Or go to your clinic wherever it is you go to your doctor. Don't just take stuff off your friends. That's not gonna help you. So hopefully I've given you guys good information today. This covered the entirety of the chapter. Relatively short considering my other videos. If you need me, you're more than welcome to do a Zoom call with me. Just set it up. You're more than welcome to call me on the number I posted on the announcement somewhere. And you're more than welcome to email me anytime. I check my email several times a day. I just really hope you guys are doing okay. I really hope you guys are doing okay. Let me know if there's anything I can do to make things easier for you. I'll do it to the best of my ability. But seriously, between the hours of 9 and 9, you can call me. I have my number, but I actually forgot it because it's a Google number. All you have to do, if you call me using the Google number, just say, hey, I'm this person. Say, oh, it's I'm Susie Cream Cheese. Call me. All right, guys. Happy Wednesday. You guys are awesome. Keep pushing. We're almost done. We're in the home stretch, and I'll be posting exemption information in a hot minute. Okay. All right, guys. Have a good one.